oftentimes when you're giving speeches, and obviously I do a lot of work related to rural areas, you always talk about what are your bona fides in rural, or I'm married into it because my wife is from the far northwest corner of Nebraska. But today, part of my bona fides is with the healthcare delivery system. Having been in a severe bicycle accident only about 6 weeks ago, so I've been through the hospitalization and still dealing with recovery. So that's that's my excuse for remaining seated here this evening. The knee isn't cooperating really well tonight. I'm going to set the stage, provide the general context, because you've got an excellent panel following me with lots of more specific information about what's happening here in Iowa. So I'm going to give you the sort of national picture of what is really underway in healthcare delivery and finance that is transformational. The change is just huge. Iowa, across the board, is a vanguard in a lot of the change, and the change is well beyond what's in the Patient Protection and Affordable Care Act, otherwise known as ACA or Obamacare. I will talk about the ACA and its relationship to the change, but I really want you to understand that the change is far more dramatic and extensive than what is in the ACA. And I'm using the phrase triple aim for a lot of this, and as I go to the next slide, I need to acknowledge, because I didn't get it into a footnote on the slide, the term triple aim comes from the Institute for Healthcare Improvement. I believe recently they've even copyrighted the term, and I just read that in an email yesterday and thought, oh my goodness, I forgot to footnote the slide to make sure that I'm not violating a copyright. So for the videotape in particular, I wanted to make that point because it's not in the slides you have. Whoops. This was simpler than I was doing here, sorry. If you just move it, then I think I just use this plus sign. Yeah, okay, thank you. The triple aim is a really handy tool to use to think about sort of global change in healthcare, because it focuses on the three elements that are critical. Element one is better care, and I'll do each of these in turn in a moment. Better care is focused on individuals, better health focused on populations, lower cost, rather self-evident. The triple aim goals, as seen through the Patient Protection and Affordable Care Act, are summarized in these bullets with detail to follow. Better care, that is the care for me as an individual, is promoted in the ACA through affordability, but I want you to understand the connection between making care more affordable for me, that is giving me an insurance card and some essential benefits so that I can more readily afford to go get the care, does not equate immediately to better care. It equates to better access to care, but better care is the treatment I receive once I'm in. And so there are provisions within the ACA consistent with what's going on in the private sector to improve the quality of care that each of us receives every time we encounter the system. Better health through a focus on patient panels in the ACA, so some of the reforms that I'll talk about and my colleagues will talk about more specifically in Iowa really generate out to broader either patient panels in the terms that healthcare providers understand and insurance plans understand. That's the people that are insured by, in my case, the University of Iowa is self-insured, so the patient panel is the patients from the University of Iowa. Population health, a more general community notion. And finally, lower cost is addressed in the ACA through some, what I've always called administrative price setting, going back to my political science roots, which means Medicare decides how much it's going to pay. And it lowered some of those payments. Some of those payments were lowered by the ACA, so that's lower cost. And system reform that is in the ACA that is underway now. I'll throw out the term this afternoon of accountable care organizations as one of the leading examples of system reform in the ACA intended to achieve this third aim of lower costs. So the ACA and better care, the affordable coverage through insurance that meets essential benefit requirements. And there's a lot of discussion of this right now because of the rollout of the ACA and because of people being told their plans are not being renewed for next year because it doesn't meet what in the ACA are essential benefit requirements. Parenthetically, that applies if the plan was changed sometime after the ACA was passed. When you hear people talk about plans were grandfathered, in the language of the law, you're grandfathered as of the time the law passed. So a lot of policies, like a lot of well-marked policies here in Iowa, have been the same during that time. They remain the same going forward. But in other states around the country, particularly places like California, there was a lot of change in those plans just in the last year. They don't meet the essential requirements. Therefore, they're not eligible under ACA. Now, what the better coverage means, though, is, and this is what all the hoopla is about right now, is you have to be able to examine what are the possibilities, either as an individual, as a small group, as a large group. So there has to be a basis for fair comparison across those plans. And then the power of market incentives to drive affordability because of the notion of pooling a larger population. Let me take just a moment to explain this because I think it does get lost in a lot of what the media bites are able to do in the 30 seconds or 20 seconds on a newscast. The idea of a competitive market is that there is a pool of customers that's appealing to health plans, whether it's a Coventry plan or Cooperative Health or Wellmark or Humana, whomever, that if they enter a market, it's because they see a pool, and by a pool we mean people from low risk to high risk, all pooled together. We can offer, if we're a health insurance corporation, we can offer a plan that is competitive in the marketplace to that. So that was the idea behind the creation of marketplaces and the ACA's intended effect of making coverage more affordable, particularly for the population that prior to the ACA had no health insurance, and for the population, and being a rural analyst, I really stress this one, and for the population who had coverage, but it really did not lead to affordable health care because of incredibly high deductibles. You know, you had to spend up to $15,000 in a given year before your insurance benefits start kicking in. In those situations, routine access to care is still not affordable because it's still out of your pocket. You are covered at very high levels if you do something like I did, but you're not covered for lower. So the intent of the ACA was to achieve better care by making the care affordable so people would seek it and receive it as needed. Another element for better care in the ACA is promoting quality through the use of incentives to get providers to focus their attention on the value of the services that they deliver. There's a term that's used a lot called value-based purchasing. So with the ACA, along with a lot of other initiatives, again, that I'll speak to in a couple minutes, the ACA is trying to adopt those approaches to change how care is paid for, to drive providers to think more in terms of the value of the service and not the volume of the service. And that's the important distinction. All the financial incentives in programs like Medicare are to deliver more and more services because you get paid each time. Well, if instead you bundled all of that, one of the reforms I'll get to, into one payment, you don't have the incentive to itemize 15 different charges. Now you really want to set up a system that is within that bundled payment level and meets the quality requirements that are part of getting the bundled payment. So that's what the ACA is trying to do very early in any results of that. From the ACA, we actually know more about those kinds of programs from what private sector initiatives have already been doing. Those include, by the way, patient satisfaction as one of the measures that is related to the payment for the delivery of services. The ACA and better health. There's a shift in a lot of those value measurements to ongoing health status as opposed to a particular surgical outcome. Both are there, but what's being measured now is the indicators for people with chronic conditions like diabetes. Are they stable over time? And the relationship of that to how you're either paid or not paid, because you may get paid based on what's called a capitation, which is a payment per person per month, in which case you want to keep people healthy. Or you could get paid with what's called shared savings, which means if you spend less money for the care of that patient next year than was spent the previous year, you capture some of the savings from lowering those expenditures from one year to the next, all which comes with minimum quality expectations. And that bar for quality goes up as we're able to measure it better. I make this point because this is very distinctly different than what some of us remember from the 1990s. During the 1990s, there was this move toward let's pay for total care, and there was this capitated payment, but there were no quality measures associated with it. So all the financial incentives were in place to drive down the volume of care, either appropriately or inappropriately. The use of quality measures is a way of trying to adjust the volume of care appropriately. Because if you drive it down because you're denying services that are needed, quality will drop, you won't get paid at all. That's the principle that's behind that. Strategies to try to keep patients healthy, which then spills over if you're doing this for the patients that are coming in through Medicare and Medicaid and through the new markets, that should spill over to the general population. And then I think, frankly, because I come from a college of public health and I'm sitting next to some of the people who are administering these programs and doing, I think, a good job here in Iowa, Title IV of the Affordable Care Act is all about healthy communities. And actually, being in Iowa, our delegation has a lot to do with it, particularly Senator Hartman and his role on the Health, Education, and Labor Committee. Finally, the ACA and lower cost. There are two immediate impacts. Well, no, I'm sorry, there are one immediate and one short term. The immediate is the lowered payment to Medicare providers. That happened almost immediately. And that happened by lowering the rate of increase. The Medicare providers are paid on an annual increase basis from the federal government in the price setting for those who are providing what's called fee-for-service. If you go in and you're not part of a managed care system, those payments increase each year. What the ACA does is lower that rate of increase by what in the statute is called a productivity adjustment. That just means we're going to lower the rate of increase and you guys figure out how to live within that lower rate of increase by improving your own productivity. So that was an immediate. The reduction in payment to Medicare Advantage plans, which now cover up to 20% of Medicare beneficiaries, is phased in over time. We've not seen all of that yet. We've seen the first year of some of that reduction. The shift to value-based purchasing that I described earlier is intended to both enhance quality, which is why I talked about it under better quality, but also lower cost. And then reforms like bundled payment, which means if you have something like a total knee replacement, instead of separate billing for the physician, separate bills for the hospital, I'm still getting some from the few days I spend in the hospital. Instead of all those itemized bills, one payment, and that payment predetermined covers all of from shortly before admission through shortly after discharge from the hospital in that example. Accountable care organizations, we are blessed with multiple ACOs, to use the acronym here in Iowa. We have, I think it's now 4 Medicare ACOs. We have a number of private ACOs with Wellmark. Again, as I said earlier, these are efforts to generate shared savings and then share those between the payer, Medicare or Wellmark, and a provider system generally. So parts of Trinity Health, parts of the New Alliance are in these ACO arrangements. No payment for what are called never events. If something happens in the hospital that should not have occurred in the hospital, but is really the fault of the hospitalization, Medicare will not pay for it. And there's a list of those that grows every year. And non-payment or lower payment for unnecessary hospital readmissions. So if you're discharged from the hospital and the care you receive is such that you're hospitalized again within 30 days for the same reason, the hospital will not receive full payment for that readmission under Medicare. So those are ways in which the ACA addresses lower cost mixed in, as you can tell, particularly with never events and hospital readmissions, that's mixing it in with quality improvement as well. Now, the ACA is only part of the change in healthcare delivery and finance that we are seeing all around us now. It's hard to know the direction of influence. As a public policy person, which I am, I would typically talk about Medicare's or public policy's influence on the total environment. The changes are happening so rapidly, both public and private, I'm not sure anymore which way the arrow's going. I think it's going both ways. Sometimes something will happen in Medicare, and you'll see a spillover effect in the private sector. I think with something like ACOs, it is both ways, because there were private ACOs before they were established in the Medicare program. Medicare jumped from 0 to 250 in the span of a little over 2 years, so it's now having an impact on everybody else because it grew so fast. It's both ways. Why are we doing this? Well, one of the things that's going on is squeezing out the cost, and it's beginning to have an impact. There's a recent report about a week and a half ago from the Council on Economic Advisors. I have a copy of it with me. It's 50 pages long. There were some press releases that were much shorter. The bottom line is the rate of increase in healthcare expenditures has slowed since 2007. And it has slowed beyond what all the economists of any particular persuasion, whether they're conservative or liberal, are in agreement now. The slower rate is more than just the effect of the recession. Something else is going on. They haven't agreed yet on what that something else is. I just was with my seminar yesterday, and it looks like it's a cumulative impact of changes that we are seeing, anything from very large corporations, Fortune 500 companies. I've recently moved from Nebraska, like Union Pacific and Omaha, that have lowered their annual rate of increase because they've got strong wellness programs in place, to lowered payment from Medicare. That is having an impact. It is part of what's slowing it down, to some of these reforms. Some combination of all of that is now affecting, but not enough yet. I was just looking at that report again this evening, and it's clever how they do this. They say the rate of increase is 1.8. It's 1.8 above the overall rate of increase in the economy. So there's still a gap there between economic growth and activity and healthcare, but it's shrinking. Why? In part because the system itself is getting smarter and leaner. What does that mean? That means that the delivery system, hospitals, physicians, nursing homes, are figuring out how to do things leaner. Is actually a slight reference to what's called lean approaches toward management. We teach those in our management programs, and we're using case studies here in Iowa of a lot of our systems that are doing that, and they're squeezing out a lot of administrative and other costs. And everybody's role is changing as this occurs, and this is where families and all of us around the table start coming into play. We're past what I would call the point of no return. Now, I was thinking of the song from The Phantom of the Opera when I wrote that. My assistant came up with a different figure for it. But you get the idea. The pressure from the payers is such that there's no going back from this being smarter and leaner and continuing to squeeze out costs. There's a shift underway to consumers being more responsible. And I think a lot of us, and based on personal experience in the last 6 weeks, are in for a surprise that if we're not more active as consumers, we're not going to be participating in better care and better health. Because the reforms that are being put in place are assuming that we will be more engaged. And some of the payment changes that are being put in place. We have to understand the role of deductibles and co-payments. There's no free lunch. And the idea, there was a good editorial in one of the papers, I don't know if it was Wall Street Journal or New York Times last week, the idea that a single premium payment means there's no other payment during the year. No. and the need to understand quality of care, who provides what quality, if you're doing something like total knee replacement, becomes important. So a shift to consumer responsibilities, and the behavior of providers is changing because of those incentives. You know, the shift from volume to value is making a difference in how providers approach patient care. I'm hopeful, speaking personally, that it also means providers shift to what I call patient-centered care, where they really pay more attention to us than to a lot of other things. I'm not entirely convinced that that's happening based on recent experiences, but I'm hopeful that it will be happening. And I know the incentives in policy, public and private, are going in that direction. So what's going on? The challenge of transition, it's a, you know, that sign that Christy found for this slide is really appropriate. I don't really know where the heck the arrows are pointing for sure. I just know that huge challenges for providers. Some of you represent rural districts. Critical access hospitals, a leading example. Boy, the challenge for them right now is really severe. They know they're going to have to change from a system that is paying them one way to a system that's going to start paying them a little less some way. They don't know how yet. For payers that are using information systems differently, they're using information to help manage care and help address population health needs. That's very different than using them solely to develop payment systems. So how we do that, I mean, we're teaching data analytics very differently in our Master in Health Administration program than it would have been taught 10 years ago, because we're using the information and data analytics to talk about patient care more than we are management of a system. For consumers who need to learn more and be engaged in decision making, huge change underway. Some key players that are involved in this that you'll want to interact with: healthcare leaders. They're changing the way they deliver services. So they're changing both clinical changes, of course, that's always going on, science advances, but changes in how we organize the delivery of care. So the role of telehealth is changing how we deliver services. The role of hospitals is changing. The role of providers changes as different providers do different things, whether it's NPs and PAs, nurse practitioners, physicians assistants, or it's family practice physicians who are doing things differently because they're managing patient-centered medical homes, pardon all the jargon, changes, and changes in finance. State and local administrative agencies like the ones you'll hear from today, some of whom are heavily engaged in implementing the ACA, and a lot of the public health functions, I think, are coming to the fore. I know that accountable care organizations around the country, because that's where we do a lot of our work on the research side, are realizing they need to be thinking about public health, and they're beginning to reach out to public health agencies and vice versa. That's very new to what we do. Analysts, hopefully you'll get help from people like myself, and consumer groups and what they're able to do. What is the path before us? I thought about Yogi Berra, but we already took the fork in the road. But sort of like Yogi, I'm not sure we know where it's going. We just took it. I think it is a long and winding road because we're not sure exactly where all this is going to end up. So there's going to be bumps, there's going to be cracks, there's going to be the kinds of things you're hearing about with ACA implementation. I think those are relatively modest compared to what is really underway in the sort of structural change in the delivery and finance of care. So we're not yet sure of the final destination, but I will say this. I'm quite sure, and I think most people involved in this, that the final destination will be a marked improvement over what we had as recently as 5 years ago. Because we are working toward achieving that triple aim: better care for patients, better health for populations, and lower costs. I'm going to close because I do direct a rural center, and I chair an expert panel in rural health that's been around now for more than 20 years. And we've done a lot of thinking about, well, we're going down this road, what are we trying to achieve? So I'm going to close with some thoughts that we have about what we're trying to achieve in rural healthcare at least. We want a system that's affordable. And part of affordability is that costs are equitably shared. So affordability doesn't mean dumping everything on the government. It doesn't mean dumping everything on healthy patients only to pay for everybody. It means some equitable sharing of costs, and for us in rural, the equity is really important. It's accessible. Primary care in particular in rural places is readily accessible. So as we engage in some of these reforms and we talk about things like provider networks, we're very concerned about how those are defined and what standards are used. Community focused with a priority on wellness, on personal responsibility. So again, here in Iowa with the community transformation activities of our health departments, with the Blue Zones initiative, that's what we're talking about, community focused. High quality. Quality improvement is a central focus. It will generate, if it's done well, it will generate all the elements of the triple aim. And patient-centered, that there's a partnership between the patient and the health team. Central points we have regarding the change: we need to preserve flexibility in how we design a rural health delivery system. We need to take advantage of things like telehealth. We need local access to public health, emergency care, and primary care. No matter all the other changes that go on, those things need to be local. Expand and transform primary care using the patient-centered medical home as a framework and using all the primary care professionals that we have, including nurse practitioners, physician's assistants, in the most efficient manner that we can. Oops. And the last, use health information to manage and coordinate care. I talked about that earlier. Here it says patient records, registries. Deliver value in a measurable way, and then use that to help drive payment change. Collaborate to integrate services, so not necessarily consolidation into one big system out there, but learn how to collaborate across systems even to integrate services at a local level, and strive for healthy communities. So that's my effort to give you a general framework. I know it was a lot, and I had to resort to some jargon occasionally, but there are websites at the end that you can go to get help, and we can further direct you to other places as well. So I'll close with that.
Before we move into our panel, we have about 5 minutes for questions, which, based on my experience, will be no more than 2 questions. And so, does anyone have a question for Dr. Mueller before we move into our panel discussion?
I thought you had one earlier, yeah.
Yeah, I had presented in my intro econ class that I teach every year some of the information on healthcare spending. And as I know that you know, and probably everybody else knows here, the United States, both in percentage of GDP and per capita dollars, spends far more than any other country, and yet we have shorter life expectancy, higher infant mortality. We spend more and get less. And most of the other countries in that comparison, this is an OECD comparison, are countries that have far more in the way of an organized healthcare accessibility, whether it's through government-provided insurance or the British, public health. What would you say, and I've asked this of several medical people I know and don't get a real clear answer. What would you say are the real cost drivers? Why do we spend so much more and yet don't get anything better and in some ways worse results?
Well, I'll give you a multiple choice answer.
I'm sure there are multiple causes.
Which will hopefully be a little bit more clear, apparently, than what you hear from my colleagues in the medical industry. One of those is administrative expense. We have a higher administrative load, if you will, in how we have financed healthcare over the years. I've seen figures as high as $191 billion spent out of the $2.5 trillion that you could attribute to unnecessary administrative. Some administrative absolutely necessary. I mean, you need actuarials if you're going to sell insurance, but a lot of administrative costs unnecessary. Second, the way in which we have used technology in the delivery of healthcare. We've not done it in a way until very recently that improved productivity. We've done it in a way that drove up total healthcare costs, and sometimes using technology simply because it's there and overuse. And I've seen figures as high as, if you add all these up, by the way, I think you'll come up with like $4 trillion, but I've seen figures as high as $500 to $700 billion on unnecessary use of healthcare services in which technology fits as part of that. And the third of the multiple choice is really more global and I think more fundamental, and that is what drives both health status and subsequently utilization of healthcare services. So as a nation, we exhibit behaviors that drive healthcare utilization because the behaviors lead to lower healthcare status. So something like an obesity epidemic in recent years will drive that. To bring all that back to the triple aim, that's one of the reasons that people like me spend a lot of time on that second aim of the better health, and why population health or getting health plans and self-insured companies to think in terms of everybody in their company becomes important, because then you're driving down the fundamental causes that lead to higher expenditures. So those three are three of the major reasons for us.
The one thing that one friend mentioned was end-of-life care. I mean, it's just horrendous expense trying to squeeze out a few more weeks of life for someone who is otherwise terminal.
You know, when I've seen the work done by your colleagues they will point to that as a reason for any given year's expenditures. But if you try to tease that out as a reason for trends over time, it has less validity, because if you're able to stop some of that now, something else is likely to take its place and keep the expenditure high. At least that's my layman's interpretation of what I read in the economic literature. So it doesn't rise for me to the level of the three that I mentioned.
I think we'll move now, and so we'll introduce them briefly, and I ask that each of them make an opening